Good evening, everyone. I, Dr. Manisha Bis, welcome you all to today's session of Faculty Guidance webinar on COVID-19 crisis management. Today's session will be taken by Dr. Mukesh Bairwa from the Department of Medicine. He will be talking today about a very pertinent issue related to COVID management, that is treatment of choice in adult COVID patients. I request Dr. Mukesh Bairwa to please start the presentation.
So good evening, all the faculty members, all the students, and junior and senior residents. Thank Dr. Manisha ma'am to give me such opportunity to speak on the topic that is more important current situation. So I will share my screen. So my screen is visible to everyone.
Yes, it's visible. Yes.
So myself, Dr. Mukesh Verma, I'm assistant professor of internal medicine. So today we'll discuss the treatment of choice in adult patients. So I'm not a specialist in COVID-19 disease because I did not any specialization in COVID uh, infection. But yes, me and Dr. Panda, since the pandemic started, we started the treatment in our institute and we started the isolation ward, COVID isolation ward. So I will share the guidelines of Ministry and Family Welfare and what are the treatment guidelines of our institute, what is the difference between the two, and what is my personal experience regarding the treatment of the COVID-19 patients. So the objectives of today's webinar will be that we will categorize the COVID-19 patient based on the severity and management of mild cases, home isolation, and then management of the hospitalization. We will focus on the hospitalization. Then the various mode of oxygen therapy because of COVID, because of viral pneumonia. Viral pneumonia can affect the lungs, basically affect the lungs and ultimately require the oxygen. So what are the various mode of oxygen therapy and what are the experimental drugs available, the guidelines in the studies, we will discuss that. Then uh, major drugs that coming in the pandemic situation, the steroids, the role of the steroid, the dose and duration, then the cloning, and then we will discuss the anticoagulation and monitoring of patients. So if you go in the site of the Ministry of Family Welfare, Government of India, you found this categorization of the patients. Mild patients who have only upper respiratory tract infection without any shortness of breath or hypoxia. Then moderate cases, usually these patients are required hospitalization. So these patients are categorized as either respiratory rate more than or equal 24 per minute and or patients having breathlessness. And patients having difficulty, some difficulty in the breathing. Second, points for category moderate include the SpO2 between 90 to less than 93 on room. And severe cases, we include respiratory more than 30 patients with breathlessness and SpO2 less than 90% of room. So this is the classification given in the Ministry of Health and Welfare, Government of India. Some guidelines and some just our institute protocol. Patient can be divided based on the CT severity score and involvement of the lungs. If less than 25 is considered as mild illness and more than 50% lung involvement is considered moderate illness and more than 75% lung involvement considered as severe illness. So we initially divide by the symptomatology. Then we classified by the severity classification by the CT severity score. So you then the coming to the management of the mild cases, the home, what are the recommendation at the home isolation. So simple physical distancing, indoor mask use, and strict hand hygiene. Then symptomatic management include uh, fever, paracetamol, major condition, and major decongestion or antihistaminic drugs for the upper respiratory tract symptom. Then patient will be hydrated and complete bed rest. The monitoring of the temperature and oxygen. One thing of my experience with share here, the measurement of the oxygen saturation. So when the pandemic started, the pulse oximeters are certain in the market. So the question arises how to measure the oxygen saturation. So simply we can see your nails and lips and you can monitor day by day by taking a one photo of your nails uh, and then observe the changes day by day. So simple measures I observe, I use this technique in my relatives and my other patients. I I told them to send me the pictures of your nail, and then 2 days or 3 days after I checked the changes in the color, any differences in the changes in color. Because definitely, if oxygen saturation below the 19, there is a development of sinuses. So this is the simple method we can use in patients with remote area, how to measure the oxygen saturation or how to then seek the immediate medical attention if the patient is having difficulty in the breathing or high grade fever or cough. Fever usually subside in the case of COVID less than 5 days. If fever is lasting more than 5 days, that patients may go in the severe. So these patients are required immediate transfer to the hospital care center. Such as care center where some patients came with the high risk group. So at the decision taking before the home isolation, we have to take care of these patients. These are the more than age 60 year cardiovascular disease, hypertension, CV, diabetes, chronic lung disease, chronic kidney disease, liver disease, and cerebrovascular disease. This is for pregnancy. So various medical colleges, various hospitals, colleagues are telling that the pregnancy is, especially in the second and third trimester, the mortality is very high. So what are the drugs that can be used at the home? So we can the these are the according to the guideline of the Ministry of Family Welfare and the guidelines of our institute. The ivermectin 200 microgram per kg adult dose will be 12 milligrams per day for 3 days, and also can use if not a contraindication hydroxychloroquine 400 milligram BD, day 1 followed by 400 milligram OD for next 4 days. And the recent studies so the inhalation budesonide can be given in mild cases with the MDI with the dose of 800 micrograms per day. So, what are the evidence behind this? The role of the ivermectin and hydroxychloroquine and the inhalation budesonide. So, the hydroxychloroquine study, the recovery trials, they that is the hydroxychloroquine in the treatment. Thus, according to guidelines of Ministry of Health and Welfare, we have to give the treatment. Then come to the ivermectin and inhalation budesonide. So, I searched the literature and I found that uh, ivermectin, there is a multiple trials are ongoing. Uh, uh, I searched the site of the National Clinical Trial Registry. There is a 5 trials are registered, only 2 completed, um, and the results are of who are one is published last week in the JAMA. That suggests there is no difference between the symptoms, pathology, duration, illness,
Dr. Mukesh, sorry to interrupt you in between, but in between there is some problem with the voice. I think there is your voice is in between. It's not very clear, so you can just see whether there is fan nearby or like
Now
you can
it's
just
clear.
switch. Now it's better. When you are coming closer, it's better.
Okay. So these are the multi-center retrospective analysis of case-based control trials. Uh, these are not showing any significant result, but the trial with double-blind randomized control trial was done on 6 and 12 mg ivermectin for 5 days and standard therapy. So the clinical recovery within the days of 7 days is 60% in case of ivermectin and 44% in case of placebo. Similar trial was done in randomized controlled trial by Pasimetol 2020. They used 200 microgram per kg body weight uh, uh, with plus hydroxy and standard therapy. The time of recovery was in 10 days plus minus 5.3 days versus 17 days. P value was less than zero point 0.1. So this study was done in Bhubaneswar, the role of the ivermectin in prevention of SARS-CoV-2 infection in the healthcare workers. So they did around the 30 patients of healthcare workers, and they found a significant decrease the chances of the infection in the healthcare. So they used two doses of ivermectin prophylaxis at 300 microgram per kg of gaps of 72 hours, were associated 70% reduction in SARS-CoV-2 infection. As the sample size was very less. So what is the WHO advice? The WHO advised that ivermectin is only used in treatment of COVID-19 infection within the clinical trial. Without clinical trial, you can't use ivermectin. But in guidelines of the Ministry of Family Welfare, so that ivermectin can be used in moderate cases that decrease the duration of illness. Then inhalation budesonide, the recent trials were done, then that shows that with use of 800 microgram twice daily for 5 days, the best device is MDI with this case. The significance trial was published in the Lancet that inhalation budesonide in the treatment of early COVID-19 phase 2 trial of unrandomized control trial. So early administration of inhalation inhaled budesonide reduced the likelihood to needing urgent medical care and reduced time to recovery after early COVID-19. So these are the experimental recently emerged therapy, ivermectin and inhalation budesonide in mild and moderate cases. Then the coming to the management of the moderate cases. Moderate clinical category includes respiratory rate more than 24 and SPP less than 93 to 90. So these patients require oxygen support. Then AVAC proning, we provide them AVAC proning, then anti-inflammatory and immunomodulatory therapy. And we consider the anticoagulants and monitoring of these patients. So we'll come one by one. Then oxygen supports. So the question arises with the what are the optimal oxygen level we target. So the optimal oxygen saturation in adult with COVID-19 was certain. However, the target of SpO2 92 96 seems logically considered. So various mode of providing oxygen. We can use the nasal cannula, we can create a mask, HFNC, and IVs. Then we have to monitor the SpO2 like pulse oximeter, EBG, by clinically verified. So the study published in the Lancet in 2018, the mortality and morbidity in acute adult treated with liberal versus conservative oxygen therapy. The systemic review and meta-analysis. The interpret the acute illness with adults, high quality evidence shows that the liberal oxygen therapy increased mortality without improving other patients' important outcomes. So supplemental oxygen might become the unfavored above the SpO2 level 90 to 90. So these results support the conservative administration. So we try target should be the 90 to 90, not more than that 90. So, what are the various modes how to provide the oxygen to patients of COVID-19? So, one is the nasal cannula. Nasal cannula is the simple, provide low and moderate fraction of inside oxygen. IO2 never goes through up to the 40%. So, oxygen flow between 1 to 6 liter, up to the 6 liter, you can give by the nasal cannula. The advantage of nasal cannula is that the patient is comfortable with nasal cannula. He can eat and he can speak, or he can drink like nasal cannula, and he can be movements will be proper or no restriction of the movement. Some disadvantage of nasal cannula is that it cannot provide a higher amount of oxygen. 6 liter cannot be provided. And it causes dryness of the nasal, casting of the nasal. Some patients are the mouth breather. The mouth breather patients.
Dr. Mukesh, sorry, I'm interrupting again, but in between your voice is breaking. I thought there is some signal problem at my end, but I guess everybody is having problems. So there is like, you can just check whether, because in between it's breaking.
I think then signal problem will not be the problem.
Is there fan or something in your, like, you can just switch off the fan if it's.
Yes, I also have fan. Now is my voice is clear?
It is clear when you are coming closer to the mic, then also it becomes clear, but in between it's going. आप थोड़ा सा आगे आके हाँ, just try. Let's see.
Yes.
I guess signal problem भी है थोड़ा सा. Yes, you can continue. We'll just see.
Then coming to the simple mask and nebulizer mask, we provide provide 5 to 6 liter and fraction of oxygen up to the 50%. So advantage is that it is easily available in the markets, and disadvantage is that it produce high amounts of aerosol generation. So it's dangerous for the healthcare workers. Then NRBM and Venturi mask, these are the masks provide 10 to 15 liter of high flow oxygen to patients. So advantage is that these masks can be used for the patients requiring high flow oxygen. Disadvantage is similarly at the face mask that is produce high amount of the aerosol. So chances of infection is transmission of that. Then other modalities we can use combined nasal cannulas and NRBM. This provide higher FiO2. So this can be used simultaneously in with nasal cannula and NRBM. Then coming to the HFNC and IV, both can be delivers the oxygen up to the 6 liter per minute. So these are the devices we use requirement of requirement of high oxygen in the patient. So HFNC is preferred over the non-invasive positive pressure ventilation patient with acute hypoxic pressure. So various studies were done at trial between the HFNC or oxygen patient. So what are the indication of HFNC when we use the HFNC in patients?
Dr. Mukesh, sorry, but I think you have to be a little louder because I think there is a problem. People are having problem to listen. So you can just try a little louder, please. I know there is a signal problem, but thoda sa, because in between we cannot listen anything.
So my voice is clear now?
Now it's better. You can come close to the screen, and I think then it's little clear. Now it's better.
Okay, so we'll be discussing the indication of HFNC. So indication of HFNC is severe respiratory failure. When we consider severe respiratory failure is SpO2 less than 90% with oxygen at the at the rate of 15 liter with reservoir bed, or respiratory rate is more than 30, or the PF ratio, which is less than 50. And second indication is moderate category. If there is a increased work of breathing, patient will be more difficult in the breathing than we, or using the assistive muscles of the breathing. Then we use the HFNC. So, what is the HFNC and what are the benefits? So, we can remember simply by the mnemonic high flow. High means it's H for heated and humidified. It's provided heated and humidified oxygen for the patient. So, then inspiratory demand can better meet elevated peak respiratory flow demands. It's increase the FRC and likely via the delivery of IPs. So we can use these up to the type. Then if the lighter, more easy and tolerable than NIV, NIV covers the whole the mask, including nose and face, and HFNC usually cover only the nose. Then oxygen dilution is prevented by minimum oxygen dilution by the nasal then pass out the dead space and removal of the CO. We can remember. So these are the technical terms, but what are the HFNC? You have to remember these. Not require the details. What is the HFNC? How to use? Because everywhere in the wards, HFNC are there and technical staff are there. So what is the monitoring required for these type of patients? We have to. And what are the contraindications of HFNC? Critically patient who require immediate high level of respiratory support, such as NIV or invasive ventilation, or decrease of level of consciousness. So unconscious patients we can't use in. Then there is a problem in upper respiratory obstruction or patient having central apnea because HFNC only provide the oxygen support, not regulate the respiratory effort or not supporting respiration. And patient with asthma that having severe bronchitis, patient with blockage nasal passage or phenylketonuria, trauma or surgery to the nasopharynx, and patient with pneumothorax, because it's high flow of oxygen that could lead to the worsening of the. Then the complication, HFNC can lead to the abdomen distension. It leads to pressure sore over the nose, and sometimes the nasal blockage are there, and pneumothorax are also complication of that. Then what are the documents or how to the monitors these HFNC? We have to document the respiratory rate, what are the respiratory rate of the patient, and the patient we are putting in HFNC. Then we have to monitor the heart rate, and we have to monitor the SpO2. SpO2 will be more than 90, and we simply measure the work of breathing. How is patient behaving? What are the muscles he used during the respiration? He is comfort or is very discomfort. Then we monitor the flow rate and FiO2 and humidification temperature. These are the technical terms, and we simply measure by the seeing the monitor of ventilator. So there is a display of one monitor shows the flow rate. How is the what is the flow rate? 60 liter or less than 60 liter, 15 liter, or FiO2. How much we are giving FiO2. So HFNC we can give up to the 70% FiO2. Then humidification temperature, it will be normal body temperature, so we are in the humidification or chamber. Then the indication of NIV, when you shift the patient from HFNC to NIV. So the main hallmark of NIV is the assist of the spontaneous activity of the respiratory system. It assists when patients initiate the breathe. It's assisted by a positive pressure. Patients having less effort to take his or her breath. So the delivery of FiO2 in case of patients with NIV can be reached up to the 100%. Without leak, if there is a leak in the mask, the FiO2 cannot be reached up to the 100%. More useful in patient with COPD with type 2 respiratory failure because we can use the BiPAP and EPAP, BiPAP mode in these patients. And monitoring is required by the experts. So simply putting NIV mask on the patients is not sufficient. So we have to monitor the patients on the NIV, especially in this situation. At least we have to remember 2 or 3 things uh, how we can monitor the patients of NIV. So we have to monitor the what are the respiratory rate patient taking. Suppose patient is taking more than 30 or more than 40 rates, that is is very high. So we have to adjust according to the patient's requirement. We can adjust the pressure support. Then we can go up to the pressure support. Usually we provide 12 mm pressure. Then we not go beyond this. And what are the FiO2 requiring of the patient? Then we have to monitor the generation of the tidal volume. If patient is generating sufficient tidal volume or not. Then we have to check the leakage, how much leakage is there. If there is a more leakage in the system, that we have to check the fitting of the mask. Then we come to the high flow oxygen through the nasal cannula in acute hypoxic. The study randomized control trial was published in the NEG. So the studies participants were randomized in HFNC, conventional oxygen therapy, and non-invasive ventilation. So the participant in HFNC group had more ventilator-free days, 24 in HFNC group and 22 in the conventional oxygen therapy by face mask or little cannula, and 19 patients, 19 days in case of non-invasive ventilation or NIV. So in the subgroup of more severely hypoxic patient, that includes PF ratio is less than 200. So intubation rate was lower in HFNC group than the conventional oxygen and therapy. So we try to maintain the patients, more patients and HFNC subject to be available. Then one small study case series were published by Teams Patna, dual oxygen therapy in COVID-19 patient and method of improving oxygenation. So they use the HFNC NIV plus the nasal cannula. So they use the NIV mask and nasal cannula to improve the oxygenation. Then coming to the walk proning, so walk proning is very helpful in patients COVID-19 to improve the oxygenation. So this is the slides are given in the Ministry of Family Welfare, Government of India, how to be do the proning at the home or we do the in the hospital setting. So this is the 1 kilo can be below the neck, other 1, 2 kilo below the chest, through the upper thigh, and 2 kilo below the shin. So this is the position, and this is the position of the pillow. So I will the position of the proning. So then we can alter the position according to the timing or patient's comfortability. How patient can be tolerate that position. So we can change from supine to lateral, left lateral, right lateral, then coming to back to the supine. Then we sometimes patients during the feeding we can put patients on the sitting position. So what is the question during the proning? So proning should be avoided during the just after the meal. So patient take and the food. So we have to wait at least 1 hour after the taking the food. Then maintaining proning for only as much time as easily tolerable. So we don't provide force to the patients. If patients are unable to tolerate, if we will provide a force to patients, he will be more anxious and work of breathing will be more. So these are the conditions where we will avoid the proning in case of pregnancy, patient with deep in sinus thrombosis, cardiac conditions, especially acute cardiac condition, acute arrhythmia, patient having a history of arrhythmia or not having antiarrhythmic drug, unstable spine and femur fracture, patient having multiple episodes, recurrent episodes of vomiting. And so these patients should be avoid chronic condition. So what are the evidence behind the proning position? So this study systemic review was done in New Delhi. Uh, so and this study was done a similar study done in Delhi by Dr. Guleria and Dr. Karan Madan, Department of Pulmonary Medicine. So they studied they found that there is a significant improvement in PF ratio and PO2 like SPO2 during the back chronic position. Then coming to the anti-inflammatory and immunomodulator therapy, what is the role of the corticosteroid and what are the doses of the corticosteroid usually we use in the COVID patient? So we can use the methylprednisolone 0.5 to 1 milligram in two divided doses or equivalent to dose of dexamethasone. Usually duration should be more than not more than the 5 to 10 days or discharge from the hospital, whichever common cause. If patient improve within 5 days, so you can stop the steroid within 5 days. Or patients requiring oxygen more than 10 days, we can extend the dose of steroid up to the patient requiring oxygen. So usual dose will be usually dexamethasone 6 milligram or the methylprednisolone 32 milligram and prednisolone 40 milligram. Prednisolone we usually we use in pregnant female because dexamethasone we can use in pregnant. So what are the evidence major trials we done for the evidence behind the corticosteroid? So first trial was published was the recovery trial. So they used the 6 milligram dexamethasone oral and IV once daily plus standard of care and patients. So they include about 4,321 patients. So they found that it reduced mortality significantly at the day of 20. So when the recovery trials published, all trials, ongoing trials, they uh, having some problem, ethical issue because of steroid having definitely role in the recovery trial. So they conclude their trials. So the sample size will be was very low. So they different they use different types of steroids react working trials. They use dexamethasone, hydrocortisone, and methylprednisolone in three groups. COVID-19 metcoid trial they use methylprednisolone 0.5 milligram twice daily for 5 days. One major trials, the Codex randomized control trials, they use the high dose dexamethasone. High dose means they use 20 milligram IV for 5 days, then they use 10 milligram IV for 5 days, or until I should discharge. That's the standard. So they found that the results will be better than the recovery trials. So uh, the recovery trials results in showing this Captain Beer survival graph that this shows the mortality benefit in only those patients who require oxygen. So if you see uh, in the non-oxygen requiring patients, there is a uh, detrimental effect or the adverse effect in the patients with dexamethasone and the patients. So the use of steroid only will be beneficial in case of patients with who require oxygen or were critical. So the systemic meta-analysis was published and uh, that shows that these all clinical trials favor in the uh, steroid use. So major trial was the recovery trials, or other trials were the small sample size. So they use different type of steroids and equivalent dose with dexamethasone 6 milligram used in the recovery trial.
Dr. Mukesh, I think we are overshooting the time, 7:35. So I just request you to kindly wind up quickly.
I, so the role of steroid pulse therapy. So a small RCT of 34 patients in Tehran, so that pulse therapy is effective in severe COVID-19 patients. But there is no RCT on the pulse therapy. So the pulse therapy is more effective in patients with high inflammatory um, markers. So according to our institute protocol, we use the pulse therapy 40 milligram Dexona for 3 days, then we use 12 milligram, then come to the 6 milligram. Then coming to the anticoagulants, which is the more effective. So various studies done in showing that low molecular weight heparin is better than fractional heparin and novel anticoagulants better. So usual dose of enoxaparin usually 40 to 60 milligram. Fondaparin, you can use fondaparin 2.5 international units of fitness or unfractional heparin in case of renal failure. We use 500 units of thickness. We can use the oral anticoagulant Apixaban 2.5 mg. So we should remember the contraindication, that is recent active bleed and platelet less than 25. So other than this, there is no major contraindication of using the anticoagulant therapy in COVID-19 because of COVID-19 is a hypercoagulable and hyperinflammatory state. So we have to use the anticoagulation. Then we coming to the monitor. Finally, how to monitor the patient. So clinical monitoring, including work of breathing. Then we have to monitor the hemodynamic instability, maintaining euvolemia. Either you measure the IVC diameter or you have to monitor the intake output to look the signs of dehydration. Then we have to measure the changes in the oxygen requirement. If patient is improving, suppose patient day of illness is at 10 or 15. If patients suddenly required oxygen demand, so we have to monitor that. We have to think that patient has something other than the COVID pneumonia, maybe superated bacterial pneumonia or maybe the thromboembolic complication. Patient may develop pulmonary pneumonia. Then we have to monitor the chest X-ray and CT only if patient deteriorate. Then monitoring of the lab monitors, CRP and D-dimer 48 to 72 hours. So we do the clinical recovery of the patients and deterioration or deterioration. Then monitoring of the complication. Patient septic shock, we have to monitor the PLC and the procalcitonin level. Thromboembolic complication, usually patient may acquire the pulmonary component of DVTs. We have to look the signs of DVT and we have to look about the pressure source, look about the barotrauma or pneumothorax, usually developing patients with NIV or pressure support ventilation. Then you have to use the monitor the drug effect, the side effect of drug, especially the effect of the anticoagulant. The patient may have bleed, or the effect of corticosteroid. There may be the hyperglycemia, or patients may have the loss of insomnia and some other complication of steroids. Then we have to monitor the nutritional deficiency. And lastly, not least, that we have to monitor the HFNC cycles. So thanks. Thank you, ma'am.
Thank you, Dr. Mukesh. There is, I think we are overshooted the time, but there, I can find one question in the chat box. I think Dr. Puneet sir has asked that why all the trials that you have highlighted, they were on dexamethasone, and why the Indian guidelines they are telling about the methyl prednisolone. So I think you can answer this question, one question, and then we can.
So there is a head-to-head trial between the dexamethasone, methylprednisolone, and hydrocortisone. So there is a one head-to-head trial between the methylprednisolone and dexamethasone. That suggests there is no difference between the dexamethasone use of dexamethasone and methylprednisolone.
Okay.
So dexa is slightly costlier than methylprednisolone.
Okay. And one more question I wanted to ask. I guess we wanted more time for discussion, but I can just ask one question. Is it can you just highlight what is the timing to start? What are the indications when we can decide that we can now start steroid for this person? Because nowadays there is a lot of debate that what is the correct timing to start the dexamethasone therapy.
Yes, ma'am.
So
So timing
what
of
is
the definitive